Hey everybody, I'm Maggie, and I am here with our Chief of Staff, Dr. Dan Sucato. Welcome back.
Thanks, it's good to be back.
And you might notice we're not in a clinic room right now, we're actually in one of our ORs. So how about you tell us a little bit about where we are?
So we're in the middle of an operating room, and so you can see behind us is the anesthesia cart, and this is an operating room table, and obviously this room isn't being used now, so it's available to us, and so we thought we'd do it a little bit different and be in an operating room. So this is where the action is sometimes and every day, and so you know, treatment is surgical, but sometimes it's non-surgical, and so this is one of the operating rooms here at Scottsdale Hospital.
The all-access pass that we're trying to give in
exactly.
Facebook Live.
Yep.
So for the past couple of weeks, we've been talking about hip conditions in pediatric patients. So today, we're going to get into hip preservation. So what is it? What is hip preservation?
Yeah. So hip preservation, that term has sort of taken on lots of popularity in the last 10, 15 years or so. And so basically what it means is that you're trying to do everything you can, whether it's non-operative treatment with physical therapy and other things, or operative treatment, to preserve the patient's hip for their lifetime or for as long as possible to limit the need for a total hip arthroplasty. So using their own hip joint, their muscles, etc., to sort of treat their hip so that they don't go on to have a hip replacement, or at least delay the necessity to have a hip replacement for as long as possible. Good.
So I think the other thing we want to add too is that we are taking live questions. So if you have anything, please post them in the comments below, and we'll make sure to get to them. So with this hip preservation, is there a certain age that are there certain conditions and ages that these kids are experiencing?
So hip preservation, that terminology really came out of taking care of adolescent patients and taking care of young adult patients. So if you think of the hip as a ball and socket, which is it is. I was going to bring a model, but I'd rather use my hands because I can manipulate it easier.
Good.
So ball, socket. So hips can either be uncovered, where the ball part of the hip doesn't have a nice roof over it. That's called hip dysplasia. Or it can have almost too much of a roof over it, and that's called impingement, or femoral acetabular impingement. So you have these two opposite extremes, and then there's a whole number of things in between. So for hip dysplasia, where the socket doesn't cover the ball part of the hip, it puts undue stress on a smaller surface area. That's the major problem with hip dysplasia. And then you get early arthritis, and so preserving the hip, you do things to make that situation better. Femoral acetabular impingement, where there's too much coverage, and that can lead to early osteoarthritis too. And so on both extremes, you have on one extreme hip dysplasia, femoral acetabular impingement, and then in between there's a whole number of different things that go into those two diagnoses. So things like slip capitofemoral epiphysis, things like Perthes disease, that can lead to both hip dysplasia as well as femoral acetabular impingement. So it's somewhat of a complex number of conditions, but it funnels into this concept of let's do what's appropriate to prevent total hip arthroplasty being necessary at 20, 30, 40 years of age, and hopefully never, but at least into the older age group.
So then for symptoms, what are some things that people should be looking out for? Especially, I mean, there's all these different conditions, so there could be a wide range of things that parents should be looking for.
Yeah, and so getting back to your other question of age, that sort of plays into this question. So if you see your child limping on a consistent basis, and that could be anywhere from 4 years of age, or when they start walking for that matter, but usually in the 3 to 4 to teenage and beyond period, limping, and then you say, hey, Michael, is your leg hurting? And they say no, but they consistently limp. That's a good sign. So visualizing your child as they're walking or doing activities, running down to first base, if they're just limping all the time, consistently game after game, that's something to think about. Pain, so if they have thigh pain or front of the hip pain, that's coming from the hip joint. Thigh pain can be coming from the hip joint. So if they have consistent thigh pain on one leg more than the other, that's an indication that the hip is a problem, or potentially a problem. Sometimes it doesn't mean it's a problem at all, but those are sort of things, consistent day after day, week after week symptoms. Front of the hip pain, side of the hip pain, back of the hip, so in the hip area if you have pain, Those are sort of things to think about. And then you see your physician, and then a diagnosis may be made. It may be, listen, they just have a little strain, or maybe they have Perthes, maybe they have a hip dysplasia, maybe they have a subcapitofemoral ptosis. So all those sort of things are important to think about.
So when they come to Scottish Rite, what is it that people are going to be looking for in so that we are preserving this hip? What is it that you're going to do as a specialist to try to preserve it, and then maybe there's exercises or stretches that they should be doing to kind of help with the health of the hip?
So like many things that we take care of, hip problems can be very complex. And so we have an incredible team with lots of people with various talents in terms of their discipline, and sort of a multidisciplinary approach is really important. So obtaining a very good history and physical exam is really important. That's done by our medical providers. If they have a condition that needs treatment, then at our disposal we have specialists in physical therapy, really experts in hip physical therapy.
Okay.
We have experts in diagnostics, so having advanced imaging for MRIs. And MRIs of the hip are a little bit different than MRIs of the spine. There's lots of variation and lots of different techniques that are necessary to do it well. Do it well in children, do it well in adolescents is different than I'm going to order an MRI of the spine, which is generally pretty uniform. MRIs of the hip are sort of specialized. And so you have to have somebody who really knows what to look for, how to get that image. So imaging specialists are really important. And then if the patient were appropriate for surgery, then you have to have a big team that can really do the variety of things that are necessary. So we have folks who are specialized in hip arthroscopy. We have folks who are specialized in open surgery, so more traditional surgery. And then the various techniques, and we use our sports team because they're very good at arthroscopy. So Dr. Ellis is our hip arthroscopist. Dr. Badescu and I do open surgery. Dr. Harry Kim has a big interest in Perthes, and he spoke a couple weeks ago, and also avascular necrosis of the femoral head. So we have what I would call sort of a hip preservation study group and hip preservation group of surgeons and non-physicians, therapists, et cetera, who take care of the patients. And then we also use our psychologists, because hip pain that's chronic wears on your mind, and it's really important to have the psychologist involved. And so it's very much a team approach.
Right, it's multidisciplinary.
Multidisciplinary.
Definitely.
Yep.
So what about complications long term as they become adults? I know we talked about potential total hip replacement. What are that might be the extreme. So what are some of the in-between that people should be looking for as they grow up? Yeah,
so ultimately we want to see, as patients leave this institution at 18 and maybe even a little older, that their hips are maximized with respect to function, maximized with respect to pain, so limiting their pain and trying to get them pain-free. And then biomechanically, and that's really important, that we want to preserve their hip, give them the best situation so that long-term they can avoid total hip arthroplasty. So things like osteotomies for hip dysplasia, where we take the socket and we get it free from the pelvis and we rotate it to a normal position. That's a great operation. That's complex. Dr. Badescu and I spent time with the guy who developed that procedure in Switzerland, Reinhold Gans. It's been incredibly successful here. We have great expertise in using it. Hip arthroscopy. If somebody has a big labral tear and they have femoral acetabular impingement, that can be taken care of either arthroscopically or with an open technique. And it really depends on the patient, the complexity of the situation, and so there's lots of different things that are employed to preserve the hip over time.
That's awesome. So I think we were starting to get into some of the research that's done with this. So maybe let's get into the anchor study that we do, and maybe also the prospective evaluation of hip preservation, so that people understand, that is a big part of how we're treating our patients.
Yeah. So I think we know a lot, and we are better, we meaning our institution and many others, but understanding hip pathology and the opportunities for surgery have been really expanded through the last 15 years or so, and we've been on the cutting edge of that. And so for every adolescent, as an example, for every adolescent patient that comes through with hip pain or hip condition, we enroll them in a registry. It's not a study that says we're going to try, you've got to pick out of a hat and you're going to pick this treatment or that treatment. It just allows us, parents give a signature to say we can collect data on this patient and just do what we would normally do, but give us an opportunity to collect data. What is their hip range of motion when they first get here? What's the hip range of motion after they get treatment, after surgery? We run them through our movement science lab, so state-of-the-art movement science lab, so we can study before treatment, after treatment. So every patient really, or every person that comes here gets, we create a data set on them so that we can study them in total, in aggregate, to say, how are we doing? What can we do better? If we're doing the same thing tomorrow that we're doing today, we probably haven't gotten any better in terms of treating patients. So we do a lot of research to make sure that we're doing the very best for each patient. Dr. Bordezzo and I are involved in this Anchor study group. It's a multi-institution study group in North America of experts in the field of hip preservation surgery. And so it's called Anchor, and it stands for the Academic Network of Conservational Outcome Research. It's a mouthful, so we had to write it down to make sure we got it right. But it's run by a number of institutions, and we're part of it, and it's been very successful in terms of pushing the science forward.
That's awesome.
It's important.
Very cool.
Yep.
So I think we have time for one more question, kind of wrapping things up. So I think what parents maybe want to know is activity level. So how do these kids, they're going through this condition, and we're trying to play it safe, and as an adult, don't want them to have surgery.
Yeah.
So what is activity? Do they have to be limited weight bearing? Do they have to stay away from sports or the things they like to do? Yeah, great question. So ultimately, the goal is to get children back doing what they normally do, to sort of give back their childhood, give them back their childhood. And so for hip dysplasia, for example, if they underwent a Gons periacetabular osteotomy to reorient the hip socket, those patients are on crutches for 6 weeks. After 6 weeks, they start fully weight bearing, and by 3 months, they're back doing everything they want to do. We have lots of patients that have played sports at a very high level, that the goal is get them back to that high level of activity. And so one of our billboards has, a hip dysplasia patient that went back and played, and he's playing college football. So, that's the goal, is to get them back to the activity that they're doing. Right. And so both on hip dysplasia, femoral acetabular impingement, both patient groups and everybody in between, we want to get them back to their full activities. Now, sometimes, occasionally, you can't get them back to their full activity because their condition is pretty significant, but we've gotten them back significantly closer to normal than they were when they first presented to us. Awesome. Yeah. Well, this is a good session in our operating room. Very cool that we could come back here. So that's a wrap on hip conditions for now. So tune in next week, and we'll be back on SRH Access. Thank you. Thanks, Megan.